Thank you, Nancy. I appreciate that. As a quick review from the last presentations, the first presentation was Hospice 101. What is hospice and what hospice is not? And in general, we would say, of course, hospice is a Medicare benefit with Part A for 6 months of life when the prognosis of a patient is that they have a life-limiting illness and they have 6 months, give or take a few months, one way or the other. We know that it is not an exact science, but it is an art, and it is to determine that this patient is approaching the end of their life, and it is an educated guess by the physician making the referral, and then having the patient and the family agree that this is a philosophy of care, that they want to be seen generally at home or the nursing home or the assisted living facility, personal care home, and they want to have their care directed at comfort rather than cure. The second talk that we had was on pain, and pain is a symptom that I think most of us worry about as we approach the end of life. It is that symptom that can really make our lives very, very difficult as we approach death and we're trying to get things in order and we're having pain. Pain can really get in the way of really experiencing closure at the end of life. And I think pain and other symptoms associated with our disease processes are really what hospices really focus on, so that the person can have a better quality of life. And it is about quality. Quantity is important, but generally speaking, most people would say not at the expense of quality. And today, the topic is going to be on the trajectories of death and dying. And the trajectories of death and dying are essentially what happens to the patient, the individual who has a life-limiting illness and then is told to have a terminal diagnosis, a diagnosis that will lead to death, and what happens over that period of time remaining, and in the shape or the curve of the decline. As we stated during the first in-service, we said that good health is just the slowest rate at which we experience the dying process. Every day we lose a little, and every week and every month and every year we begin to experience how we are losing our physical, and hopefully we're gaining something else. And I think we do. We gain wisdom as we get older, and we begin to see that, as the saying goes, some of the sweetest fruit is borne by the oldest trees. And I think as we get older, we do see that when we've lived, I'm 53, and as we get closer, the average life expectancy, as we were saying, is 78, 79 for women and 77 for men here in the United States. As we approach every year, we see every season, come and go, and we begin to see have we really had a satisfying or a good life. And generally speaking, if we have had a good life, I think we can then see a good death, because we have accomplished what we've wanted with our life, and we have lived our life as if today may be our last day here on earth. So we do see that overall everyone wants to have comfort. Everyone wants to be comforted by their loved ones and by the healthcare system, and it's really a right that I think we want to have. We want to be comfortable, and we want to be in control. We don't want to lose that control as individuals as we get into the medical system, and as we're being treated for initially curative intent, and then when we lose that ability to be cured from our disease process, we then know that all that can be done is to palliate. And palliative medicine is a Latin word that means to cover, and it covers the symptoms related to the disease process that is occurring. And as we know, as we get older, if we miss the prime time for heart attack and then for cancer, eventually we may then find that, Alzheimer's or dementia or debility, old age, will then be what will get us in the end. We do have, this awesome medical technology that we have here, especially in the United States, where we can prolong the life at the expense of the quality of life. And when you see that the peak and the #1 cause of death is cardiovascular disease, followed by cancer, the next most common cause of death is stroke, then followed by COPD or chronic obstructive pulmonary disease, emphysema, and chronic bronchitis. But if we don't have those illnesses and we live long enough and we live well into our 80s or 90s, we're seeing more and more patients that have end-stage frailty, debility, or old age. And in fact, that does make up the majority of the patients that we see that come on hospice. About 46% of those patients that come on hospice have debility. And we would say cancer compromises about 22% of the patients, and then heart and lung disease is 16%. Sudden illness is 7%, and other diagnoses, liver and kidney failure, is about 9%. So you can see here, if we did a pie-shaped diagram, that it would show that the biggest portion of that pie is frailty or debility. And it is because we do escape the heart, the cardiovascular disease, and we may not escape it, but we have such effective surgeries and treatments for that. And then we also may have good treatments for cancer, and we may even cure the cancer, but eventually we will face overwhelming frailty. And no matter how old we live, it is then the most common problem that we'll face and that we see in hospice care. The trajectory of death and dying, all people do not move at the same speed towards death. If we look at trajectories, we talk about a macro diagram where you would see on the large scale that you have 4 different trajectories on the large scale. On the micro scale, we'll also review today, that is the component that how we respond to the diagnosis of a terminal illness. And so it's very complex. It's like a mosaic. It's not defined specifically in stages, although it has been defined that way, but it's just a mosaic of different experiences, because generally speaking, the type of person you are is a way that you will cope with your coping mechanisms to the disease process that's considered terminal. But first, to begin with a macro scale, the 4 types of disease trajectories were elucidated back in 1965 by a pair of doctors, Dr. Glaser and Strauss, in 1965. And they said that there was the first obvious trajectory is sudden death. Sudden death only occurs about 5% of the times. If you have an accidental death, or you have a sudden heart attack, or you have a major catastrophic event where the person dies in their sleep very suddenly, they have what we would say is a minority trajectory of decline from good health, or actually not good health. They just did not know that underneath that appearance there was a catastrophic illness waiting, and then to sudden death. And the second trajectory that we see is we call it the roller coaster entry, re-entry type of trajectory, that over time the person has an event, they have decline, and then they have improvement, and then they have decline again. And it's a sine wave. It's kind of like up and down, but over a period of time you eventually come to the point of the realization that the person is going to be in the terminal phase of that illness. And that's characterized generally by patients that have organ failure, heart disease, congestive heart failure in particular, COPD, lung disease, liver or kidney disease can also have that type of a sine wave appearance, but in particular the heart and the lung, the cardiopulmonary system, generally gives us that second trajectory. The third trajectory is the trajectory where you have the patient that is diagnosed with cancer, and the person's functional status is very good, but at the time of diagnosis with the cancer, you then see a very steady downhill trajectory over a period of a few months. And this was a trajectory that was initially instituted for the Medicare benefit of hospice in 1982, and then it was opened up to other disease processes. So cancer is the classic hospice trajectory where they have a diagnosis, and then in 6 months or so the patient sees that they come to the end of their life. And then the last trajectory is the trajectory where you have the specifically patient with Alzheimer's, dementias, or frailty, where you have a very low functional status to begin with, and then it just happens that they have a very, very gradual, very, very gradually slow, lingering type of trajectory. And as I said, a large part of the population of the United States now, escaping the other trajectories, will see this old age debility or frailty diagnosis. And those are the 4 different types. And just to be able to plan for the patient, the family, and the physician, I think when we know what type of trajectory we're going to likely experience, you can see that the person that goes in and out of the hospital for the second one, where you have the roller coaster trajectory, it's one that the family invests a lot of time in the patient to go into the hospital, out of the hospital, and they get better. And it seems like each time that they get better, they do lose ground. And it is one that really creates a lot of caregiver burden, because you do, and it creates a lot of anxiety of what to anticipate, that it's going to happen again and again. And I think a lot of the educational piece for the patient and family is that, to anticipate and to help them realize what are the likely scenarios to occur, and then at what point in the investment of this treatment process do we say that it's time to go home and have those events treated at home with a palliative hospice approach, instead of an approach where they're treated and then they have to go to the hospital by ambulance over and over, because that's a very, very tiring, very stressful, physically type of thing for the patient, especially when they get transported from their home by ambulance to the hospital. So there's a lot of discussions that center around that. You know, at what point do we then now consider staying home, so that then we can have the outreach and have the nurse come see mom or dad at home, or come see me at home. I don't want to go back to the hospital, because when I go to the hospital, it really takes a lot out of me, and it also isolates me. It isolates me from my loved ones. The other trajectory where we were discussing that you have a patient with cancer, that's also a trajectory where there is a lot of anxiety, there's a lot of stress with the loved ones or with the caregiving. They require a lot of help, and I think hospice does a wonderful job, especially with the symptoms related to the cancer diagnosis. In particular, you know, we're experts in pain control, symptom control related to the disease process. It may be anxiety, it may be depression, it may be shortness of breath, it may be nausea, it may be having trouble sleeping. You know, we really focus on those things to improve the quality of life, so that person can prepare for the end with their family and loved ones, and not focus so much on the symptoms that they're experiencing.